Good morning, everybody. If you'd like to take your seats. There are still one or two seats spare, so thank you very much. Good morning and welcome to the first ever Healthwatch Norfolk Live. Just before we start, there's probably a little bit of housekeeping. First of all, if you do hear a fire alarm, we'd ask that you follow me because I shall be first out of the door, I promise. Through the main doors, and the forum staff will direct you to the fire assembly area outside the building. And the toilets, for those of you who need to know, are just outside. So you go out to the main door on the left and you'll find them there. We also have a quiet area for anyone who wants one. Just ask one of the team and we can find you a quiet area where you can watch the meeting online. As you may be aware, we've struggled to find a BSL interpreter to interpret live today. We will be putting a fully BSL interpreted version of this meeting online as quickly as we can. And we will also have a subtitled version online by the end of the week. In fact, technology permitting, hopefully by the end of today. Our journey to this event has been a little bit unusual. Today started life as our AGM, which gave us the opportunity to give you an update on our work for the last 12 months and look ahead at what is to come. Unfortunately, it seems a bit strange, when I saw on my car today it was 6 degrees as I drove here, so we hardly can remember the extremely hot temperatures, but those very hot temperatures that we experienced earlier in the year meant that we had to postpone the live event with an in-person audience and transfer to an online-only event with just a few hours' notice. That formal business part of the AGM is available to watch online by searching for Healthwatch Norfolk on YouTube. We did still want to have the opportunity to talk more about health and social care, particularly with the major structural changes which began in the summer with the start of the integrated care system, bringing the operation of health and social care much closer together. So we've come up with the idea of Healthwatch Norfolk Live. And later this morning, leaders from both sectors will be here taking questions around the changes and what they will mean to you, the patients and the communities in Norfolk. Also this morning, we'd hoped to welcome GP and author Dr. Richard Pyle, but he'd regretfully had to cancel earlier this week because of staffing pressures in his practice, a common theme, I'm afraid. We're delighted instead to be welcoming Mike and Shannon from Thriving Workplaces, who are going to talk about resilience in the workplace. It's also fantastic that we are full for today's event with every seat allocated. We're heartened that so many of you are keen to get involved, to ask questions, discover more about health and social care, and engage with us as we continue our work as the voice of patients and a critical friend to those who work in health and social care. I should just pause at this moment and say I've been in post as chair of Healthwatch Norfolk for just over a year now, and the reason that I particularly wanted this job was because I had huge respect for the two senior execs who are at the top of the tree at Healthwatch Norfolk, which is Alex and Judith. And I'm absolutely delighted to say that every single person that I've found that works in Healthwatch Norfolk and is connected with Healthwatch Norfolk are doing an absolutely outstanding job of listening to the patient and sharing the patient experience with our health and social care providers. It is a huge privilege for me and a great pleasure to be part of this organisation, and I hope that you'll hear more about what the organisation does during today. And, of course, listen to the answers to the questions that we've been posed by people on the run-up to this event. So with that, I'm now going to hand over to Alex, Healthwatch Norfolk's Chief Exec, who's going to take us through the past year's work and give you an update of 12 months' work in around 5 minutes. Good luck, Alex.
Thank you very much, Patrick. I'm very much welcoming everyone here this morning, and a special welcome to Louise Ansari, who is our National Director for Healthwatch England. So thank you for coming as well, Louise. It would be remiss of me not to start this marathon run-through without thanking board members for their ongoing support. They helped to provide me with the most outstanding team. Without the team, I would not be able to stand in front of you feeling immensely proud of all the work that they undertake, ensuring that the views of patients, carers and residents are heard. I would also like to take this opportunity to thank Norfolk County Council, in particular the public health team, for their ongoing support. They provide us with money in order to undertake our work. Through the team's dedication and hard work, our brand awareness has increased considerably over the last 12 months. This has been borne out by research that has been undertaken by Healthwatch England on a national basis. We've spoken to local community groups, refugees and asylum seekers, sex workers, young and old people alike, with a wide range of conditions and problems. So on to some very quick statistics for you. We've had 2,033 reviews of health and social care services. We've had 833 general inquiries. We've produced 16 reports providing information, research and recommendations for both commissioners and providers of services. Work we have done includes collating and communicating COVID-19 information, looking at the issue of domestic violence amongst older people on behalf of the Safeguarding Adults Board, collating the issues around access to NHS dental care and keeping up the pressure on decision makers for something to be done, an ongoing saga, reporting to both the Health Overview and Scrutiny Committee, as well as collaborating with our national colleagues. Collaboration with the Queen Elizabeth Hospital in King's Lynn to help them improve communication, with a focus on a range of communities, including some great work with the College of West Anglia students. Our thanks to the commitment of all staff involved from the Queen Elizabeth, who helped ensure that this project was a huge success. Communication for cancer patients was another focus, with people telling us they would like to choose the format of their appointments. Letters have now been amended for patients, and a prompt card created to help patients think of questions ahead of their appointments. Digital access came under the spotlight. Patients told us they wanted a clear and concise document telling them about the digital help available, clearer language on doctors' websites, and more video consultations for those who want them. We chatted to people helped by the Norwich Vulnerable Adult Service. Commissioners are now currently considering rolling out this services to other areas of Norfolk following the positive feedback that we received. We've unearthed issues around getting interpreters and translation in healthcare if English is not someone's first language. We will be going back to health organisations in the next year to find out what progress is being made with that. Sharing information is very much a two-way process and is a key component of a successful health watch. Primary care colleagues have been subjected to some very bad press recently, sometimes justified, but frequently unwarranted. We worked with the general practice in Norwich to explain how GP practices were working during and after the pandemic to help patients understand how things work and the wealth of experience and help available to them. Our face-to-face engagement work continues, and our team go out to both clinical and non-clinical settings to discover people's health and social care experiences. I'd just like to remind you all that when Healthwatch started in 2013, there were two of us. There was a woman called Christine MacDonald, who's in the audience, and myself, and we sat in an office in Heatherset thinking, what are we going to do? That said, at that point, we received a grant of £658,000 from the County Council, which is money that came down through the Department of Health, but with additional funding that the county very generously gave us. Our current funding is in the region of £338,000, some 50% less 10 years on. In 2013, we had a team of 2. We now have a team of 17. The grant monies, for which we are very grateful, pay about 1/3 of the work we undertake on behalf of the public. Other monies are raised through commissioned work. Healthwatch is a credible organisation, working tirelessly to try and effect change. As we move forward into the next 12 months, the work will increase. The advent of the Integrated Care Board and associated partnerships provides massive opportunities for radical change in service provision. A taste of some of the projects that we will be undertaking include understanding people's awareness of patient participation groups, what they can bring to the table, an engagement report focusing on GP access, work on use of digital tools to enhance service provision, mental health transformation, looking at cardiovascular disease with public health, working with One Norwich practices to understand the benefits of the walk-in centre, and working with adult social care looking at standards and quality of provision in care homes and dom care settings. And finally, a review of a specialist care in Norfolk following the damning report in relation to the tragic deaths at Causton Park. To conclude, I would like to assure you that all the team will continue to work to ensure that the patient voice remains at the centre of everything we do. And we will strive to ensure that we are able to meet the demands, the ever-increasing demands that are required. Enough from me, but before our guest speakers, here's a chance to look back at our work over the last 12 months, condensed into a couple of minutes. Thank you very much for listening.
Relationships and communication, the two issues at the heart of everything we do. 12 months ago, we were just coming out of COVID-19 restrictions, which impacted on all of us. It meant tricky paths to get better care and support, and issues around access. Now we're at the start of a new, more joined-up health and care system, bringing services closer together and the opportunities this brings. So let's look back at the past 12 months and what we've achieved. Firstly, the numbers. We published 2,033 reviews and received 823 inquiries from people needing advice. We published 16 reports about improvements you'd like to see, and our team of 13 staff and 16 volunteers helped us carry out our work. So how have we made a difference? We collated and communicated COVID-19 information, examined the issues of domestic violence among older people, and collated the difficulties people were facing getting NHS dental care. Those who are deaf and hard of hearing were asked how care could be made more accessible when going to their GP surgery. A deaf and hearing loss charter was created to help staff understand the needs of patients, as well as ensuring technology was available to help book appointments and know when they're called in to see their GP. Cancer patients told us they wanted a greater choice over the format of their hospital appointments and sometimes, understandably, found them stressful. Changes have now been made to patient letters and a prompt card created for those patients to think ahead about what questions they want to ask hospital staff. There was a recommendation to expand the vulnerable adults service across Norfolk. Currently operating in Norwich, it gives targeted health and wellbeing support to people in the city with no fixed abode, who all praised the help they were given. The Queen Elizabeth Hospital in Kings Lynn asked us to look at how they communicate with patients. We spoke to a range of people through surveys, focus groups and targeted engagement with students at the College of West Anglia, and recommended the hospital uses a number of different methods and channels to keep both patients and the community up to date. And talking of consultation, we also looked into digital access to doctors, including more information about the digital options and freshening up the language and labelling on the Footfall GP surgery websites. As the way GP surgeries help and assess patients evolved, we tried to explain those differences and went into a Norwich surgery to follow the patient journey and give an insight into what happens when you get in touch with your practice. Our volunteer team also remained very busy looking at documents, attending virtual meetings and helping our engagement team. Talking of which, once restrictions lifted, we were back out face to face across Norfolk, gathering your health and social care experiences to look at trends, concerns and good practice and feed that back to health and social care leaders. Looking ahead, lots more work is on the horizon. Our focus on accessibility continues with the Your Care Your Way campaign, ensuring patients get information in the way that is right for them. We'll find out what people believe the barriers to getting care from their GP are, and also discover how patients and communities are finding their voice through patient participation groups. So lots more projects and studies coming up. That's just a snapshot, as well as a very busy continuing programme of engagement. So we're getting ready for another exciting, challenging and rewarding 12 months where our relationships and communication remain key.
Good morning, everyone. My name's Mike, and my colleague Shannon here. Hello. We're both from an organisation called Thriving Workplaces, and we provide help and support for organisations, voluntary groups, and any groups that help people throughout Norfolk. So we've been doing this since 2016, and today we're going to talk around resilience in the workplace, but not just in the workplace as it used to be, but in the workplace as it is now. So lots of you will be remembering those times in the pandemic where you're trying to help your groups, maybe remotely. Now you're maybe back into the community a lot more, but we still have some of those things that are left over, such as that kind of always on technology, emails, and things that can kind of interrupt our out of work time. So we're going to look at how you can cope with that, how you can help your colleagues, your other people that are helping in the community, and make sure that you have the energy to give to your patients, friends, colleagues, and workers as well. So if you pop the slide on, you'll see here that we're going to have to look at what is resilience first. So if we hold it on that slide for a moment. So has anyone heard of the word resilience? Yes. Yeah, you've all heard of the word resilience. It's a kind of buzzword at the moment. It's something we see a lot. But it doesn't really mean always what we think it does. It doesn't have to relate to stress. Okay, it doesn't always have to relate to stress. It can relate to overcoming challenges in the workplace and in your life. Okay, so resilience now is becoming more commonly talked about around workplaces and around groups that we help people with. And the reason for that is there's much more awareness now around our well-being while we're working. So there used to be a very clear distinction between your work life or your community, your volunteer group, and then your home life. There's more of a clear distinction. Nowadays, those things are certainly blurred. And that has partly become due to technology. So we are much more interactive with our work. Rather than when we go to work, we clock on, we clock off, and we go home. So those lines have been blurred, especially through those pandemic times. A lot of our work has been to help groups and organisations work their way through that change. Okay, so there is a change, and there is something now we need to look at. So resilience, if we pop onto the next slide, the dictionary from the psychology states that it's the ability to adapt to difficult or challenging life experiences. Okay, so sometimes a lot of you have heard maybe in schools, in colleges, they're actually talking more about how to make young people more resilient as well. You'll hear that more and more. And it's something we're also quite conscious of, where in the workplace there'll be some demands placed upon people. That is a really common theme. So what can actually happen is it's something we need to look at as something we can improve on. So it should be something that is learnable. It's something we can actually help each other develop. So we can become more resilient. It's not something we're just born with, and that's what we have for the rest of our lives. It's something we can develop, and we can help each other with in our work. And that allows you to be better at helping others, doesn't it? Especially now with the, that frontline worker, NHS scenario, we've had a lot of cases where their mental health or their well-being is affected, which has then affected their ability to help others. So the more resilient we can become, the better we are at helping other people, and doing our work to the best of our ability. So anyone can learn and develop these behaviours, thoughts, and actions. And that's really important to remember because it's a positive thing. It's a positive way to think about it. All right, so resilience, starting off, is something to think about as challenges we have and how well we cope with them. So what things have we got in place? What things can we do to make ourselves more resilient so we can help others better and do our jobs better? On to the next slide, please. So the workplace, as I said in the early part of the talk, is actually, I would say now, a widespread, open place now. It's something where work isn't necessarily something where we're just doing at a set time. Sometimes people work from home. Sometimes people work hybrid. The way we work has changed quite a bit over the last few years. So if you're helping others, you'll find that sometimes you may respond to emails late in the evening. You may be checking through something at a weekend. I'm sure most of you at some point will do that, and that's probably because you have a passion for your work, which is great, and it is fantastic that we do have this passion to help others and to deliver on our KPIs, or we're a commissioned service, like a lot of you folks will be as well, so there's certain pressures placed upon you to make sure you're delivering on what you say you're going to deliver. So it's relevant to the workplace because what we do in our work does affect our home life as well. There's a lot of talk about work-life balance, isn't there? Work-life balance is a very common theme. It's things that's talked about regularly. But actually, I would say it's very difficult to balance those things all the time. You know, sometimes there may be times where you do have to work harder, especially, as I say, with care, social work. It's very difficult to just have that distinction between work and home life. All right, so that's why it's definitely relevant in the workplace. Next slide, please. Oh, I think you might have skipped a few there. Let's just drop back a bit. Let's have a look. Okay, no, if we go back, that's fine. We can work back. So I'll fill in the gaps on this one. So what we need to understand is the World Health Organization have classified stress as the next theme around their kind of health and well-being kind of going forward strategy, really. So the forward thinking part of the World Health Organization has found that workplace stresses and stresses placed upon our lives is the next theme they're going to look to work on. Okay, it's the next mental health crisis, as it were. So what we need to think about is what emotional demands can sometimes be placed upon us while we work or while we're trying to help others. So let's take an example. Let's think about frontline care. Let's think about care work. Okay, so try and think of an emotional demand placed upon colleagues or people you know in that sector that they may be faced with in their work. Has anyone got any ideas? Anything at all? Any demand placed upon them in that? Yep, go for it.
The person in front of you bursts into tears and unloads on you.
Yeah, exactly. You know, so that's relatively common, I would say. Not being from that sector, we do have organisations we work with in that sector.
We work with quite a lot of, whether it be in the care or GP surgeries, for example, that we do offer a lot of mental health first aid training and what have you there. But that's quite a difficult situation to be placed in, especially if you don't know what your first reaction would be then either. So
exactly, but it's a very, very common thing. So that's not a difficult thing to just switch off from, and it can carry over into out of work time, can't it? Anything else? Anything else? Yep, go for it.
Too much to do and not enough time to do it.
Exactly.
Preach.
Exactly. It's very, very common, isn't it? Too much to do, not enough time to do it. Sometimes there's layers of workload, isn't there? You know, so there's an overall project or something you're trying to achieve, whether that's in the community or in a private business. You know, it's the same kind of outcome, isn't it? There's an additional stress placed upon people. And it's not always easy to solve that with one answer, is it? But there's something in there, and that does place, as you rightly say, an emotional demand. And the emotional demand can then lead to other stresses in your life, and it sometimes carries over into different areas. So the point to start thinking about now is building better resilience or having strategies in place can help you work together when you have got those times of added workload. Okay? So the body, unfortunately, hasn't learned the difference between stressors. So a stress placed upon us causes a reaction. And that's just how we're built, isn't it? Yeah? So what kind of things happen when you get stressed? Give me a few examples. General stress.
Your heart rate increases.
Perfect. Great. So your heart rate increases. Why do we think that would happen?
Preparing for fight or flight.
Exactly. So originally, our bodies had that fight or flight response for very important reasons. You know, it's a really important thing to have that, isn't it? As that protective mechanism. So your body goes into that protective fight or flight mode, and unfortunately, it hasn't learned that emails at 10 o'clock at night, or added stress through workload, it doesn't know the difference. We haven't developed and we haven't evolved to actually understand deep down in those stress responses that our workload isn't something we need to increase our heart rate for, or tense our muscles, or release different hormones through our body. But that happens with any stressors to certain degrees. Okay? And it's a very individual thing, because we'll come to it in a minute, but not all stress is bad. Okay? Having some level of achievement is a good thing, isn't it? Some level of, you want to attain something, and it's a little bit uncomfortable, is a way to develop resilience. You know, when you as a team, you come back like you have here, it's been great to see what Healthwatch Norfolk have achieved since the beginning, but I can imagine in the early days, there was some struggles, and there maybe still is, isn't there, on all of us. But those struggles, when you overcome them as a team, in your group or your workplace, is a way to become more resilient and learn from those things, isn't it? So we do have stresses, and we do have things that cause physical reactions. A way to test our physical reaction today, it's a really easy thing to do, it doesn't require any effort at all. all I'd like you to do for me is just place your arms across your shoulders. It's a great way to try this out right now. And this just shows you a slight indication of how our bodies are built and why they act in the way they do. So let's all just take a big deep breath in together. So really big deep breath in. Really try and fill those lungs and then relax. Perfect. I'd like you to do that one more time. And this time, if you can, just watch Shannon as she does it as well.
I'm the assistant today, so.
Big deep breath in for me, Shannon. Really fill those lungs. And then relaxing off. And then you can relax. What you'll notice, in most of us, when we're busy, we've had coffee, we're running around, or responding to emails, you can relax your arms down now, folks, that's it, we'll start to breathe from muscles up here. So you see how high the shoulders lift, can't you? So that's one indication, if you said there may be an increased heart rate. What also happens when we're under that general little bit of stress, we're very busy, is our breathing pattern can change. So you go to shallow breathing, which is using the muscles around your neck and shoulders, rather than your diaphragm, which is in your rib cage. So what part of the body generally aches when you're really stressed and busy?
All of it?
All of it?
No, just me. All right, then.
Anybody? Where'd you get a little bit aching? Neck, shoulders. And that's an indication of why that's happening. You can see that there, that our body, because of that protective mechanism we've had since we've evolved, hasn't changed. So we still get that little bit of added muscle activity because we're not breathing in a relaxed manner. Okay, so that was just something I wanted to show you as a practical example of how our bodies respond to stress and how we can improve on those things. Perfect. Moving on. So there was the breathing activity. And yeah, that's one way. What you'll also find is there'll be other things that will happen when we can become stressed or overworked. And we sometimes go the wrong way around trying to solve those things. So our kind of coping strategies aren't always helpful. So what we'll look at today is how we can develop a few more beneficial coping strategies. Yeah. So as you said, in workplaces where it's very time constrained, you might have certain things, certain pressures, GP surgeries, the amount of patients they have to get through, there's certain criteria that always add stress to things. So we'll look at how we can still actually make a bit of an impact without just saying go and do some meditation. Because we've gone much further than that now. We've really come up with some good strategies. So next slide, please. So there it is. This just shows here. This is a really good example. We generally, if we get stressed and we get overworked, okay, naturally in our body, without actually thinking, it's an involuntary response. We start to breathe from our upper chest here, and the muscles around the collarbone, the clavicle around here, they become overworked. Which then makes it a little bit tougher to relax and do what's called diaphragmatic breathing. So nice relaxed breathing that you would do if you went out for a walk. If you went to walk the dog, you're upright, you're in the fresh air, you tend to take a deep breath from this area. Okay, and that's generally why those basic things, being out and around in nature, all those kind of very classic things that you may not think are that important, they really do help for things more than just giving you some space and time to think. Okay, so diaphragmatic breathing is something we can develop, it's something we can do, but it's one great example of how physical aspects can affect us as well. Thank you. Next slide, please. So here's a bit more, I've taken a little bit of Richard. Dr. Richard Parle obviously is our doctor, is our GP, but I thought I'd also make sure I show a little bit of how the body responds to stresses and help you understand it. And in 1 minute, you'll hopefully learn something you can take away that you may not have known before about stress. So as I say, stress isn't always a bad thing. But the great example you mentioned there around maybe an increased heart rate when we're a bit stressed out, we actually get different things happening. So any of you that have maybe had irritable bowel conditions, irritable bowel syndromes, things like that, stress does make it generally a bit worse. It's a common theme. It's something we know about. And partly due to the fact that our digestive enzymes that are released into our stomach to help digest our food are reduced when we're stressed. Because of that fight or flight, the body is trying to gear things up for more of a stress reaction. So to either run or to fight. And that means you're not going to digest your food correctly, which may lead to discomfort in your digestion. It's going to slow down your food movement as well. So we've got the digestive side of things. But we also have the adrenal glands, which, as the name suggests, produce adrenaline. So if we've got that little low level of stress, we're going to produce some more adrenaline, which is then going to mean we maybe shouldn't be having caffeine on top of that, which is something we tend to rely on and may affect your sleep.
I see a lot of people just going, yeah. Yes.
It is common, isn't it? It's very common. Okay.
We'll go through it, absolutely.
It's a really common thing. So these stresses can be perceived or not, and they may not always be something you can just fix with a bit of a rest, meditation, taking a walk. Okay, there maybe need to be some interventions you can think of together as a team. For example, workloads and managing what you can manage. Okay, that's what we're going to come to next. Thanks very much. Next slide, please. So this is a great slide. I really like this one. Okay, this tells us that sometimes we need a little bit of a challenge. We do need a little bit of a challenge to help us move forward and to also give us that motivation to keep going. So it could be helping someone in your community, you know, a challenging case. Actually, working on that would be in this part here called eustress. Okay, so this means you're having to put more effort, it's out of your comfort zone slightly. Okay, so pushing those boundaries just slightly normally helps you to respond better. So having a challenge, such as Healthwatch Norfolk in the early days, such as Thriving Workplaces, a commissioned service, there's a challenge there, isn't there? You know, we would like to help this many people have their views heard, for example. That is a challenge. It's a challenging situation. So what that means is it helps you to then, as a team or as an individual, work a little bit harder. So if there's no stress on you at all, okay, nothing placed upon you, there's no sense of achievement, there's nothing for you to push for, no goal, it's quite hard to be motivated. You know, an outcome ideally needs to be there for you to, you know, push yourself and motivate yourself. So this is all great stuff here, where we've got a bit of a goal, we can see what we're getting up for in the morning, we're helping people, you know, we've got an end game to our business or our community group. But, as you were saying, really good point, when that becomes too much, and there's too much workload, which happens regularly, as we can imagine, in lots of different settings, doesn't it? Okay, lots of different settings, care, frontline work, any of those things where we're trying to help people, it's not always easy. And that may become too much, which is where we have this thing called burnout, okay, which is a newer term, which describes the fact that there's probably too much for you to cope with at that time. Yeah, too much work for you to cope with at that time. So down the bottom, here's just a few of those examples of what can happen. So you've got those different hormones being released in your body, and your body's gearing you up to try and combat those extra stresses.
It is good actually when you look at, I don't know about you, but when you think about mental health as a thing, how many of us automatically straight away go to the negative connotations of mental health? You think depression, you think suicide, you think anxiety, you think bipolar, you think the actual medical language or potentially some self-stigmatizing words or things that we've heard around in our community. And mental health is mental health, stress is stress. We all have it, we all deal with it, but it doesn't always have to be digested negatively, does it? So stress can also be a good thing, as you said there before, in terms of actually giving ourselves something to then focus on. I don't know if many people have come across the stress container as well. It's a really good model that you can look at. It's from Mental Health First Aid England, but just actually looking at the stresses that you have in your life, writing them down and actually asking, what can you change? What can't you change? What do I need help and support with? And then being able to identify people who can then support. But it's just, I just think it's really interesting that, including myself before I did this job, 6 years ago, before I did this job, that you would think of mental health or stress as always negative, is always, oh, like that's just something else we've got to deal with. But actually, it's also about our perceptions and how we look at things. Again, moving forward now, kind of post-COVID. I'd like to say we're completely 100% out of it, but who knows? But yeah, it's just really interesting that actually stress can be positive and that you're in that kind of that eustress stage. I don't know how many people here are are we in a eustress stage at work, in our lives? No? No? But that's fine,
nice,
we're all in
it
it together, that's
exactly.
the thing, we're all in it together and yeah, it's just a very interesting thing in terms
Thanks,
of
Shan.
perceptions.
Perfect. Great, moving on. So this is a fantastic way for us to understand, moving on perfectly from what Shan said there, of how we perceive the things we've got going on in our lives. And this is adapted from an American psychologist called Stephen R. Covey, and it's called The Circles of Control. So you may have heard around about this kind of thing before, maybe not. But what it actually is looking at is there are certain things we can control, there are certain things we can influence, and there are things we can have no control over and no influence over. And there are what's called our areas of concern. We can have a concern around those things, but we can't control it or influence it. Okay, so if I give you some examples, if we pop up onto the next slide, please. Oh, maybe there is a few missing, unfortunately. Okay, we'll do it practically.
Okie doke, that's why I'm here.
Go for it. If you grab the...
It's like we knew.
I just thought they may not all be on there. So there should be a slide.
Here's one I made earlier.
There we go.
There we
Look
go.
at that. Perfect.
For those of you that can't see, I'll just cover my face, that's fine.
There we are. So the inner circle, okay, is the circle of things that happen in our life that we have full control over. So that would be my attitude, okay, when I eat, generally, how much sleep I try and get. So actively things I can do that are under my control. My thoughts, my actions, those are things I can only truly control, okay. Then we have a circle of influence around the outside. And that could be maybe my reputation, what people think of me, maybe the outcome we have at work. I can influence it, but I don't have full control all the time over it. And then around the outside, I have things that are a circle of concern. That could be the traffic, it could be the weather, it could be outside events in politics, for example.
Mortgage rate.
Exactly.
Yes.
Very good
Like it,
example.
yes.
Fantastic example. And actually, that's a really, really good example, isn't it? Because it's very timely. And that's the kind of thing that would be concerning. But unfortunately, we have no influence over it and no control over it, unless we work for the Bank of England or the government. Okay?
Well,
Which would be great. So there we go. So it's understanding that some of the things we come across in our life, in our work, with our groups and our colleagues, will be things we can control, some will be things we can influence, and some will be things we can be concerned about. And really, you can see where we're going with this one, is what area should we spend most of our focus and energy on?
control.
Exactly. Perfect. That area we can control. So it's trying to help each other to understand. So if it was an area of influence, so as one of the ladies said, you may have an increased workload. You can potentially influence that by having discussions with your team and your colleagues, couldn't you? And making it known. That's the thing. Okay, we seem to have a lot of work on here. We need to discuss this and see how we can strategize and make it a little bit more manageable for all of us. Because otherwise people will maybe assume you're okay with that workload. And I know it sounds easy, but it's trying to think about, you can potentially influence it, might not control it, but you can certainly have an action plan in place. And that's quite important, isn't it? Thanks, Shan.
I think one thing that actually really does help with this as well is that actually understanding that it's not just going to be really simple, really easy, and then the next day, oh, well, it was in my control yesterday, but it's now a concern, vice versa, we'll just live each day. Everyone will have their own inner circles and their own attributes and whatever to put in, but it's understanding that we're all going to have to work together and support each other in this, because if not, then not much is going to change and become fluid around these circles, and it is going to be hard. And I think the most that you admit to yourself, actually, there are going to be some things that I know full well I can't control, but it is going to stress me out a little bit. It is going to, it's going to decline my mental health slightly, etc. But if we're aware of that, and then, as Mike said, put those things in place or think about those helpful coping strategies to then move this around and it actually becomes quite fluid, then we can then move forward.
Perfect. Thanks, Shan.
Are you okay with that?
Yeah, that's brilliant. Thank you very
good.
much.
Thank you,
Great. Next slide. So I know we've definitely missed a few slides. So how do we build resilience? So to summarise and to come towards the end, there was quite a lot of negativity. I tried to be as positive as I could. But there's lots of things we can do to make ourselves more resilient. We can understand now how the body reacts to stresses placed upon us. It's not always in our control. There are certain things we can control. So the things we can control are the things we can put time into. So it sounds quite simple, really, when you think about it like that. So there's helpful coping strategies. And the first one, I would say, is to actually plan these things, write these things down. Create an action plan. So look at the stresses placed upon you and create an action plan. Discuss it with people, with other team members. Yeah, make sure you are actually looking to address these issues as much as you possibly can. Then it's having things in your own life that help you cope with stressful situations. Going for a walk, reading a book, seeing friends and family, being social. You know, not responding too much to those stresses by going the other, which is alcohol, you know, too much caffeine, lack of sleep. You know, it's the things that we generally do that are unhelpful that create that circle. Okay? So we'll see if we have the next slide. Perfect. So this is the way we can do it. We've got a stress container, okay, which is all the things that are happening in our life, and anything that adds a little bit of that stress over and above what we can normally cope with would go into our own stress container. We've all got a level of stress we can cope with, and everybody's very different, as Shannon said, but we do all have a stress container. Yeah, so there's things placed upon us that will go into the stress container at the top. And the way we can release these things, and the way we can be more resilient and be able to help each other and you know, get those outcomes we want from our work, is to use our helpful coping strategies. So that will be making sure you take time to see your friends and family. It will be making sure you switch your phone off if you're that kind of person who generally responds to things and gets involved in things too much out of work. Okay, it will be exercise where possible, eating well, all those things that we know we should be doing. If reminding ourselves that it actually helps to release that stress, maybe when we are busier, we're a bit more resilient. Okay, writing things down, being organised with those stresses as well, and chatting to your colleagues, your friends, other people in your community groups you're working with. Okay, so it's a balancing act, really. And you normally find when you've had a good walk, you know, you've seen friends and family, those things you were worrying about on your own when you were trying to do some work, they generally are less impactful, aren't they? Okay, so it's really important we do that. So the more stress we have, the more mindful we need to be of adding in those helpful coping strategies. Next slide, please. So here we are, coming towards the end. We can see that you'll see this in your friends, you'll see this in colleagues and things like that. When we are very busy and we have those added levels of stress in our lives, we tend to go down this side, or it's very common to see people doing this. You may recognise it in friends and family. So it's actually the opposite to probably what we should be doing, really. Yeah, over the right-hand side, we've got loads of things that you can start to think about that would help to empty that stress container. Okay, so it is being proactive. That's really important. Okay, by the thought of, you know, Healthwatch Norfolk and people in here in the room, I would say you're all probably quite organised people. Okay, I would say you're quite organised people. So
At this point, I'm now seeing everyone shake their heads, so...
you look to me like you're very organised people. So what I'd suggest you do, if you are under times of stress and you're very busy, is be as organised with yourself and your well-being as you would be with a work project or task. Because sometimes people are very good at helping others, but not helping themselves, aren't they? And I guess a lot of you are nodding as well. It's very easy to help others sometimes, but maybe not help yourself with that same level of kind of emphasis. Yeah, so put that same level of emphasis as if someone was chatting to you and saying, oh, I've got too much work on, Mike. You know, I've got so much work at the moment. I'm also not chatting to my sister. She's got problems going on. There's lots going on in my life. And you say, that's okay. Let's have a look. What's going on? Explain. You know, whereas you don't tend to do it for yourself. Yeah, so that's really important. So break down the tasks if it's a task-based issue and you're very busy. Make an action plan to address those problems. Ask for help. Talking is the most important thing to your colleagues, line manager if you have one, you know, any people you're working with. That would be the more workplace answer. Okay, but actually, in and around your work, getting outside, walking, being in nature, reading, exercising, making sure you get enough sleep.
Ensuring you take a lunch break as well.
Yeah.
How many here just casually sometimes work a little bit too often through lunch as well? Yeah, I've definitely done that at times. I'm not going to stand up here and, you know, not say I haven't, but in the workplace, being able to encourage each other, okay, you've got to be the change that you wish to see. So get yourself out of the office, even if you're not going to have a lunch, get yourself out of there, and just by walking away, taking yourself out, kind of think, oh, I'll probably come back and it'll just be as stressful. That really does kind of deplete those stress levels and decrease them if you're outside. So definitely don't work through your lunches. Give yourself at least, you don't get paid for them, do you? Let's be honest. So you might as well take them.
So yeah, as Shannon says, it's important to make sure you take time for yourself, and just the key concept here is to give yourself as much attention as you do for the people you help. So we're in a lot of businesses here that help others, especially, as you say, care, GPs, NHS type work, anything on that front line tend to be very helpful people for others. But sometimes that can let down a little bit with regards to their own well-being. All right, so it's being conscious of that and having a few little strategies in place. And also, maybe you're reminding yourself of the things you do that do help, and you maybe forget about them. So that's, you know, that walk you take, you know, that bit of exercise you do, sometimes you can devalue it. And when you don't have it is really the time when you notice, don't you? So if it gets, like for me, for example, got injured playing football, I'm probably too old for it now, I should just let my children, I should let my children do that. But the fact then I couldn't exercise and keep active like I normally do, I noticed a big difference. Yeah, so it's just reminding yourself of those good things you do, because when the time gets tough and you're busy, that's when they're really important. Perfect. Should be coming to the end. Next slide, please. Here we are, a bit of review. So we've come full circle now and looked at resilience. It was based around the workplace, because we're here today at, obviously, Healthwatch Norfolk's AGM type session, just to understand that we are in our community groups, in our workplaces, wherever we are, that still has an impact on how we feel, doesn't it? It can impact our well-being. And it should always be positive where possible, but sometimes we may need to recover from those difficulties as quick as we can. All right, so resilience is the ability to recover from difficulties and challenges that we have. We've also understood that challenges can be a positive thing. Having a goal is needed, but when it goes over and above the stresses you can normally cope with, you may get some of those side effects. Increased heart rate, muscle tension, backache, headaches, all those kind of things. So how we cope with that is quite important. So identify common themes. So if you start to feel that, yeah, I'm getting overloaded here with work, I need to make sure I'm feeding that back to whoever I can. We're going to try and work on this together. And I need to make sure I do take my walk at lunchtime, or I do, you know, go to and do some exercise, or I do set aside time to have read a book, take some time out. And you may even need to be more conscious of it as you get stressed, which is difficult, but it's a really good thing to do. So having those coping strategies in place can ease the stress and help you get the most from your day. And then finally, yeah, having conversations in the workplace, that's what we do. We help, you know, community groups and workplaces to have those conversations, to come up with some strategic analysis and move forward with things. Okay, so hopefully you've got a few takeaways that you can maybe think around your own well-being and also helping others to make the most of their day. Thanks very much.
Also, just quickly, just beforehand, I know the majority. I'm too loud anyway, I probably don't need to go near that microphone. But I know the majority of us are probably from very similar organisations, if not the same, if not Healthwatch Norfolk, etc. But if you have any friends, family, anybody who you know that are working in a workplace, an organisation, even if it's hybrid or working from home, we are here to help. We are Norfolk's free workplace health service, so we do offer so much for free. Everything tastes better when it's free, doesn't it? So if there is anyone that is potentially struggling, or they want better workplace culture, or just kind of helping to support each other when it comes to stress, resilience, etc., then do please go onto our website. I'm not very good at the whole plugging thing, but yes, absolutely, please do. Just slip into our hello inbox with any queries, questions, help. We can then have really good consultations with you guys, all free of charge, and then be able to help your friends, colleagues, family, everyone in Norfolk be a happy and healthy county.
Thank you very much.
Lovely. Thank you ever so much, everyone.
Thank you.
Mike, Shannon, thank you very much indeed. That was terrific. I think we all feel well plugged. Thank you, Shannon.
No problem.
Particularly that it's a free service as well, which I think was certainly an eye-opener for me. You mentioned very briefly the idea of culture. You've talked very much about what the onus is on the individual, but presumably also, do you actually get involved in work with the employer to look at workplace culture? You've talked about mental health first aid as well.
Predominantly that is what we do. So instead of working one-to-one with individuals, we will work at an organisational level, and instead of it, or we try to recommend, instead of it being kind of from a very top-heavy command and control management, that everyone has something to say in their workplace and can actually follow through and feedback, etc. So we really do take a whole organisational approach, but when it comes to things such as our free workshops or our mental health first aid training, anything like that, then that's on that individual basis where somebody can learn really good techniques for themselves, both identifying unhelpful coping strategies as well as helpful, and then they can, you know, if you're a better person in yourself, you can be better for everyone else, including your workplace. So kind of both, but predominantly more so for the workplaces on an organisational level.
Thank you, Shannon. And one final question for me. You've talked about mental health first aid in the workplace. How's Norfolk doing with having enough mental health first aiders in its workplaces?
So really well, really well. So we are currently working with around about 180 organisations in Norfolk anyway. We're a really small team, so we're kind of out and about all day, every day, delivering many mental health first aid sessions and kind of lessons really. Unfortunately for Norfolk, we do have a very high level of suicides, unfortunately, and this was something that Norfolk County Council wanted to really tackle on and kind of, you know, decrease as soon as possible, and that is due to many different sectors in Norfolk, such as, you know, agricultural, for example, construction, a lot of family-run businesses too, especially with COVID. So there are very still, unfortunately, high levels of suicide within Norfolk. However, by implementing, out of the 170 organisations, I'd say well over half have implemented some mental health first aiders and champions. That then takes pressure off HR, takes pressure off occupational health. It then, you know, brings together a community at work where people can then support each other. So then ultimately the aim is to bring down those suicide rates and just to help spread awareness really. So we're doing really well in that, but just unfortunately it's just kind of balancing in terms with the other environmental factors that unfortunately affect all of us. So
thank you. Good. Thank you very much indeed. Well, I certainly found that extremely interesting. I feel very strongly about the benefit of mental health first aid in the workplace and about organisational culture as well. And I'm sure that some of those topics might well crop up in the question and answer session, which we're shortly going to enjoy. But before then, I just wanted really to highlight the importance of Healthwatch Norfolk's role in engagement with the community, because without engagement in the community, we can't feed back to the health and social care providers what the patient experience is. So it really does help us to set our priorities and help form the recommendations which can help to improve health and social care. So just to talk a little bit more about that, our Head of Engagement, Caroline, explains more about how important it is in this video. Thank you.
Engagement is so important to us because we need to know what people are saying, how they're feeling and what they think of the service that they're receiving. The more feedback that we get, the more change we can make. So it's vital we know what people think. I think it's really important to be on the ground talking to people because I think we get a much clearer picture of what's going on. We can ask questions if there's stuff that we're not sure of. The idea that we go to different settings rather than just hospital or GP settings is we can hear about lots of different services. We can go to a library and hear from someone that's used a doctor's, a dentist and a pharmacy all in one go. Whereas if we visit just GPs, for instance, we'd probably only hear about that GP service. So it's really vital that we get out, embed ourselves in the community and hear exactly what's going on. Norfolk is such a diverse little county. There's so many different things that affect different areas of the county. So we have to go out and reach as many people as we can and in as many different areas with as many different backgrounds as we can to make sure we get a clear picture of what's going on and that everybody is having their chance to have their voice heard.
And thank you very much to Caroline and her team for making sure that the patient voice is heard and the patient experience is shared with the health and social care providers. Obviously, one of the challenges that you probably just heard alluded to there is of the hard to reach, the organisations, the groups, the community groups that need access to health and social care and may not get the normal share of shout. So that's one of the areas of expertise that I'm very proud of for Healthwatch Norfolk, is its ability to access and give a voice to the hard to reach. Now it's time to move over to the question and answer session. The questions have been produced by the public. I promise that there are no questions that have been seeded by me or by our trustees. They are all questions from the community. So with that, may I ask our panel to come and take their seats at the front. Thank you very much indeed. Don't they look happy? Braced, I think, is probably the expression. They will, yes, but they've got the coping strategies now, so that's fine. I think it's probably best because I dare say that not all of you will know who everybody is on the panel. So if I can ask each of you in turn just to briefly introduce yourselves, starting with you, James.
Hello, good morning. Lovely to be here and pay tribute to the brilliant work of Healthwatch. I'm James Bullion. I'm the Executive Director of Adult Social Services for Norfolk.
Thank you.
Good morning. I'm Stephen Coleman. I'm Chief Executive of Norfolk Community Health and Care Trust.
Hi, I'm Stephen Corse, Director of Finance of Norfolk and Waveney Integrated Care Board, and great to see you all here today.
Hello, I'm Suzanne Meredith. I'm Deputy Director of Public Health at Norfolk County Council.
Good morning, everybody. I'm Sarah Tuff. I'm the Director of Children's Services with Norfolk County Council.
And good morning, lovely to be here. Alice Webster, I'm Chief Nurse at the Queen Elizabeth Hospital in King's Lynn, and next week I shall be Interim Chief Executive, so 2 jobs this week.
Well, I think you'll agree that we're very grateful to everybody for giving up their time to come here this morning. They've all got really important, really high-pressure jobs. Thank you very much indeed for joining us today. James, I know that you're going to have to bail out halfway through, so I'm going to focus on you to start off with so that we can extract as much value from you before you leave us. So without further ado, I'm going to ask the first question, which is, although a national or even an international problem, what can we do locally to address the workforce shortages across health and social care? How can you make the workforce feel valued and respected? Probably pitches into something we've heard about earlier, and how are workforce issues being addressed across health and social care? So I'll start with you, James, and Alice, if I might ask you as well. So James.
I mean, it's a really crucial issue. It's probably the biggest single issue facing health and care at the moment in both children's, adults and health services, and indeed in community services. On the valuing part, so that is a kind of collective job of all of us about presenting a really positive image, particularly for care work, which I do think is seen as low skilled and low paid. It is not low skilled, is it? It is low paid, and that's a problem, but actually the skill level involved in doing the job is a matter of both public perception and and public misunderstanding, I suppose. So there's a job for all of us in promoting the workforce positively. We try locally to do that through our campaigns. So the Everyday is Different campaign or the Who Cares campaign that we're running at the moment. And some of it is nationally run for both social care and health by the Department of Health and Social Care. So there is a sort of collective job we all need to do there. I think part of our issue is pay and parity. My profession, social services, adult social services, have been calling, as it were, for a national change around social care, to have a national care wage that pushes the wages up from the current average $9.50 to where it might be for a healthcare assistant, which is around level $11.50 for healthcare assistant level 3, which is sort of roughly equivalent. So I think we can't get away from the notion that we need to pay more for care workers, and that's a job for the council and a job for the government and a job for all of us in our taxation. And then the second point I'd make is that we do need to work together as a team across this table, and we have got a workforce group, a shared workforce group in the Integrated Care Board that tries to bring a single strategy to this, to make work more generic, to try and recruit together and trying generally to improve the situation. But it's a really hard job, actually. In my area in care, there are 14% vacancies in home care. So the 27,000 people work in social care in Norfolk, 11,000 are in home care. There's a vacancy factor of 14%. In social work, it's about 20%. So and the workforce has gone down through Brexit by about another 14%. So we've got a real crisis on our hands, actually, around workforce.
Thank you.
Thanks, Patrick.
Alice, what's it like on the front line in a frontline hospital, an acute care hospital?
Yeah, so I mean, I agree with much of what James has said, but I think the other element that we are able to do and are doing with the College of West Anglia, certainly in King's Lynn, and I know we're looking at it everywhere, is about growing our own locally. So, you know, I am so old. When I trained, we went off to do our nurse training and we did it in a local hospital and so on and so forth. As I was finishing, it was moving into university and very much moved into a university-based training. We took out enrolled nurses. We are absolutely turning the tide and looking at trainee nurse associates, people being able to come into nursing and being able to have a career in their own local area. And certainly through the College of West Anglia and through Anglia Ruskin University, we are starting to see over-subscription for our 20 places. We're going to be offering 20, 30 places 3 times a year. So, you know, that is really, really enhancing people wanting to come into nursing and to make a career of it. And I think that has to be the valuing bit. People need to know that they may start at a point, but that is not the only point they'll get to, that there is a career. We're working with our other providers, and Stephen and I, through our teams, have had conversations about how we flexibly use our workforce. So you don't just come into an acute setting, you may be able to go into the community, you may be able to go into social care, and that is being led by us as providers, but also through the integrated care system and the workforce board that James has talked about. But it really is about, if we can bring people in locally and they can see what we have to offer, we will start to get a workforce that is committed to Norfolk and staying with us.
Thank you, Alice. Which actually brings us on to another question. And again, I'm reading the questions that we've been given. I would say that we've got many more questions than we're going to be able to cover and give these people enough chance to answer them. So we will be, we have asked that the questions that don't get spoken about today we'll get written answers which will be posted on a website. So every question that I have got on my list will get answered, not necessarily in person, but in the next few days. And I guess this is probably one for you, James, and also for Stephen Course as well. At the ICB launch event, Tracy Bleakley, the CEO, talked about focusing on alleviating pressure from hospitals by investing in patients to be treated in the community. Who will actually lead on this work? What part do stakeholder partners see in helping with this laudable ambition? And what do they think that success will look like? So, James, do you want to kick off on that?
I'll kick off, actually, but Stephen, next to me, it is to some degree the lead for this work. So I think it'd be really useful to hear from him. That's not a pass to you, Stephen. Just to acknowledge his lead.
If you've given him enough time to
yeah, I'll say a little bit about it from a social care point of view, but as the leader is here. I mean, it's a crucial shift that should be at the heart of the ICB's ambition, the ICS's ambition, actually. So the Integrated Care Partnership and the Integrated Care Board together, I think the emerging priorities are around prevention and community services. So just to state the obvious, we need to have that priority and a bit of a target for resources A, resources B, and a change over that period of time, whatever period of time our plan is going to be over. So we do need to set ourselves that sort of target. But it's absolutely evident, and it's evident from the government as well in the last week or so, the part of the problem with our hospital system is the flow. I mean, it's really ugly, all this language. So I apologise for the language, because this is about people and their rights to care and their rights to health care. So, but I'm going to use a bit of technical language. So the flow question of someone going into hospital, having their treatment, and then being somewhere else to get their recovery, that is rather stuck in our system. Every day there are around 600 people who are in our acute or community hospital system who really ought to be, finish their treatment and need to be somewhere else. Part of the answer is increased social care. Government have just announced 500 million nationally. It's a drop in the ocean, I would say, but there you go. At least it's better than no drop. And that's to try and beef up the social care response so that we can enable people to go back home, mainly. So there is definitely a plan that we need to have in our system to do that. And Stephen has been helping us coordinate how the hospitals and social care and the community hospitals work together. But there's no doubt that we've got to find the trick of investing in the community with our money whilst not having all that money and taking the money out of the hospital. And there's a sort of bridging that we need to do that, you know, Stephen has the challenge of trying to oversee the money for this bridging problem of how do you invest there before it reduces there. And that's got to be the aim of the ICB, I think.
Stephen.
Yeah, so in my experience, so I think we need to be at the forefront of that for NCH&C, and I would say East Coast Community Health. It's not just about NCH&C, is that? And the other bit I would say is how I would come at this is community isn't just statutory agencies. There's a lot of voluntary sector. There's a lot of community resource really that can help use this. And in previous work experience I've got around mental health, we did create the shift, but we did that not just with secondary care. We actually engaged a lot in the community and put our money into that as well. I think there's a bit of, it's not just, we have to invest in it, we have to invest in that infrastructure. I think there is a recognition that historically it hasn't been set up that way. It has been set up as more as a bit of a competition, and one loses, one gains. So some of that shift that could happen from, say, acute hospitals into community hasn't always been enabled because the money's not flowed that way, and the staff resource that we've talked about hasn't moved that way. But I think there's some really good signs that we're going to be able to do this. So Alice referenced, you know, we are working really closely with NNUH, Queen Elizabeth predominantly, because that's our patch. And I know EC do with the Paget, about what's the vision for it, what does it look like, and then what are the stages that we need to go to move through that. The other one that I think is a real pressure that is in there in the community is the primary care element as well, because primary care is under significant pressure, and so every bit of it is, and it's how we untangle that a bit. And I think it'll be a staged process. I think too often we talk about this like you're going to move from A to B, and it's really straightforward, and it just happens like that. There's got to be stages across it. So I think there's a number of layers to that. Workforce is the biggest one underneath it all. We can't underestimate the workforce challenge, that even if we had the money, I don't think we've got the workforce there at the minute to do it quite like that.
It's probably a good opportunity to ask Stephen about the funding. You know, the ICB, or the integrated care system, very much brings all the funding under one umbrella. So you can do a great deal to kind of direct how the members of the ICB, the ICP, actually function together. So I guess there's kind of two questions that I'm leading to here. It's not on the sheet here, but we've talked about it already, which is this idea of prevention, which clearly has a long-term goal. You can't measure prevention in a few months or even a year. It might take a long time. So there has to be a funding commitment to that. But also this idea, as James and Stephen have just talked about, this idea of collaboration. How can your role help to take the long-term view and to encourage the collaboration between the if you like, the public sector and the third sector? Because that seems to be, you know, one of the real possibilities of the new integrated care system.
Yeah, absolutely. I think through the work that we're already doing through things like our place boards, the work that Stephen and James have described around what we're doing around trying to move people into the most appropriate place of care, the challenge we have around workforce with our workforce boards, it's those kind of things that we need to strengthen and develop relationships, not just within health but within local authorities, within the voluntary sector, are going to be the key challenge and the thing that we really need to get right. We have around £2 billion to spend as an integrated care board across our health system. and often we're kind of responding to short-term challenges. I think the key for us in this work is to think about not only how do we get through some of those immediate challenges, but what can we really put in place that will give us the long-term benefit to really achieve some of these things we've been grappling with for some time, whether that be workforce, whether that be the flow that James talked about earlier, or whether that be through some of the more immediate challenges we've got that we know we kind of see seasonally each year. So I think for me it's just about how we really strengthen those relationships and bring in not just health partners but right around our kind of community and our population to really think through what is it that our populations are telling us and what is it that we can do with those structures to really put in place something to ensure the £2 billion that we do have is spent effectively across the system.
And again, this is me asking a question rather than a question from the sheet, but how quickly is the community going to notice a difference with the introduction of the integrated care system? And I guess that's probably a question to all of you, really, as to when you feel that this new approach is going to enable us to make significant changes, improvements.
I think sometimes I think elements of the community will feel that really quick. So some of the work we're doing now is there's a different tone and there's a different way of working it. So again, I'll use Alice as an example. We've had really quick conversations around some stuff that we can just get on with and do quite quick around some of our community pathways. We're looking at things like heart failure, about our discharge work, some of our discharge work, some of frailty. So I think there are some areas, and I think one of the bits we've got to do to start to create the narrative and the trust that we are moving on it is really tell that story as it's happening. I don't think we can get, I think the wider community, that will take a bit longer because it will experience it across so many services. So I think there is a bit that we are moving on a number of things. I wouldn't want anyone to walk out with the impression of this is, sometimes we're in danger of make it look so big and so complicated and it's over and it's always jammed tomorrow. There are things moving. We have to get better at kind of explaining that. And then there are some really difficult ones that are going to take a bit longer to sort out. But let's be really honest about that and let's say kind of the journey that we're on with it and what we're all doing to help it.
Okay, thank you. Sarah.
Yeah, I just thought I'd comment in respect of when we might think about the ICS in a very structural way. But for me, what the ICS is an opportunity for us is just to change our collective mindset. And I think picks up a little bit on what just Stephen said. So it doesn't require us to kind of wait for a new policy or a new kind of set of agreements that we need to reach. We actually are all signed up to the notion that we need to work together. We know if we do that, we do things better, that we need to think about our collective resources. We need to be focused on our local community, which means we need to use our data to help us understand what the community looks like. So none of those things are easy. They're easy for me to say. They're not so easy to always do. But I think what it is shifting is that way of thinking, which is inviting everybody to come round the table and have those kinds of conversations and to get on and do things quicker. And then kind of then put some additional time into the bigger and more knotty issues. And I just wanted to say something about children in hospitals, because there's often we will think of adults when we're talking about the flow, as James made reference to, but we only have a very small number of children who are in hospital settings, but actually that small number is still too many children. There's a lot of work taking place, again, to think more preventively. So how do we stop children getting into hospital rather than the notion of how do we get children out of hospital quickly? Because often when they've arrived at hospital, actually they're very poorly. So then they do need the care that they are needing to receive. So actually it's a very different approach, is how do we avoid that? And how, as money comes through, there are new monies coming through, family hubs is something we're going to start to be able to talk about over the next 12 months as an initiative to bring agencies together that will bring more locally based support to families that are more easily accessible. So I think we're all moving in the same direction, inviting people now to have those conversations.
Thank you.
Thank you.
Suzanne, from a public health perspective, first of all, I dare say the public health, your team and your colleagues probably had as tough a time during the pandemic. And I know that the director was certainly became the face of the community for an awful lot, for a lot of us. And certainly I can say thank you very much to everything that the public health team did to try and keep us as safe as possible. But we've heard talk just now about when is the community going to notice a change? When are they going to experience a change? And we've just heard talk about how important it is to share data, and that must be something that's right at the heart of what you guys do. Do you want to just add some comment on that?
Yes, so data and information is really vital, I think, in terms of us all working together to really understand what we're currently doing and also measure our successes going forward and being able to really monitor what we're doing. At the moment, we are still restricted in some ways by the way we gather our information and share it together and analyse it together. But there are plans in place to make some changes, to make that easier, bearing in mind, though, that we still have to meet the appropriate data protection and regulations, but ways in which we can share data, use it differently, and bring all our skills across the system together in terms of making sure the right person is able to do something on behalf of the whole system. So it's a really exciting time at the moment, thinking through, by becoming a system, how we can do that.
Thank
definitely.
you. And I know that your team does publish a huge amount of data accessible through the Norfolk County Council website. And I commend it to people if they want to know more about the state of play in the community. But if I can just think a little bit more about data, one of the other things that I know that we're all looking forward to is the introduction of a shared patient care record. And James, that must be particularly difficult where you've got public sector providers, private sector providers and so on, particularly in your area. Is that something you want to just let us know a bit more about how it's going?
Yeah, definitely. I mean, I think we've got a data challenge internally, so GPs can't necessarily see the same data that hospitals can see all of the time because they're on slightly different records, and in social care and health there's the same issue. And then between social care and the providers, and we work with about 700 employers for social care, and they don't have access to our records either. But from December this year, the shared care record will switch on. So we've been working on this in the background. At the moment, it contains health and care data. It will be healthcare and housing data pretty soon. And there is the potential then for care companies to also have access to it, and ambulances, for example. And we're not trying to merge our databases or anything like that. We're doing a new data sheet that's in front of all of our information systems that will draw out the key shared bits of data. So if you are an ambulance and you do turn up at someone's home, you can see that the person has a mental health social worker, for example. And that changes the environment you're in and your head environment for what you expect. You know, if you can get access to that on the journey of the ambulance. And that's the vision, that everyone will be able to see other professionals that are involved with that person. It won't take away the need for them to record on their own systems, but it is a pretty crucial beginning. And I think Norfolk and Waveney, we are rather behind on this agenda. So we have got to do some pretty nifty catching up over the next 3 to 4 years, but I'm hoping that will make a big difference to practice, how people understand their jobs, and it'll tackle this issue of risk averseness. And this is another, sorry for the jargon, but lots of people go to the lowest possible risk level. So an ambulance driver who doesn't know that this is normal for Betty to behaving this way, that's pretty normal for Betty. Don't convey Betty to the hospital, ring the sister of Betty. I'm sorry to be, you know what I mean though, but to humanise it. If you know that, if you've got a shared care record, you've got half a chance of thinking, that's fine, the risk is okay. If you don't know anything, then you'll do the least risky thing, which will be to take Betty to A&E probably.
And I think
Alice,
just picking up on James's point, the really important thing is you can have a conversation with the right person first time. And I think, any record, of course, we need something written because you need to know and you may not be there at that time, but it doesn't take away that human contact with the right person first time. And I think that will make a huge difference to the amount of time that people spend trying to find somebody that's engaged with a family or not. And I really do think, as you say, we are slightly behind the curve, but it will make a difference to the individuals that we're working with.
And from a community care point of view, is that going to make a big difference, or is it a challenge, a nightmare?
It's definitely a challenge. Again, I think it just falls into what James said. We see a lot, particularly with our urgent care response, where if somebody was able to know at 7 o'clock at night who that person may have seen, that there's been an interaction, it just enables you to ask a few more questions that gets you a better outcome than at the minute. I think we are defaulting to. We turn up at accident emergency. I did a couple of 2-3 hours with the ambulance service just to get a different perspective on that. And what was really stark was, as the crew were driving there, it was a gentleman who was actually under the care of NCH&C, under the district nurse, and had seen the GP that day. I found that out after, because I went back and went, what happened? And the guy got taken to A&E, had a really supportive family. But even if he had to go there then, it's the follow-up, it's what happens after. So people are spending too long there as well, because the rest of it we're not quite connected enough. So I think it can't come quick enough. We are behind. We've got to put a lot of work into that, and I wouldn't underestimate culturally. It's not just put the technology in and the data; it's how people use it, and we've got to get people into that mindset now.
Sarah,
just again from a children's perspective, the really important aspect of a shared care record is for child protection as well. So there's all those care elements that we've just talked about, but being able to very quickly see who might be who else is involved or is known to that child will allow information to be more swiftly shared, picture built very quickly, and so that the right response can happen in an appropriate fashion. So very critical from that point for safeguarding the welfare of children.
thank you. Yeah. Question off the sheet. How will public health and social care help us all to tackle health inequalities? Suzanne.
I'll start then. So I think it's important to think about the factors that contribute to our health, for starters. So it's not just access to healthcare. So the things like the environment in which we live in, so whether that's air quality or the home that we live in, the social aspects such as having a job and having education, but also whether you've got a good supportive friends and family network around you, that's important too. And also our health behaviours ourselves, whether we don't smoke, whether we remain active and take exercise, whether we eat well. Those are all things that contribute to our health. So when you're looking at inequalities, we know we have differences in health outcomes across different communities in Norfolk and Waveney. Some of the worst outcomes we have are associated with areas with the largest deprivation. But also, there are other groups that experience health inequality. So if you're thinking of socially excluded groups, some of the things that Healthwatch have talked about today around perhaps people with no fixed abode, perhaps communities such as Gypsy Roma traveller communities, people with severe mental illness and so on. Even people in rural communities experience health inequalities, even men versus women and so on. There is a gender differences in certain aspects about health inequality. So there are a range of different communities that we need to think about when we're looking at inequalities. And I would defy anyone in this room to say you're either not involved with either someone from a community that would benefit from work, or you're planning services around either the environment or social factors or health behaviour or so on. I think everyone in this room can have an impact in terms of how they might help us tackle inequalities. But from a public health perspective and how public health can work with everyone in this room, I think at least 3 roles I can think of straight away. One's around system leadership. So you've mentioned our Director of Public Health, Louise Smith. She is our system lead for prevention and for health behaviours. So that's one role that public health have. In terms of partnerships, and we've mentioned working at place boards, and public health are very much involved in working in local partnerships to try and take that local action to improve health inequalities at a local level. And also you've mentioned data and intelligence, and public health have a vital role both providing that data and intelligence about where our health inequalities are and also about some advice about how we might go about addressing those. And today we've heard a wonderful presentation about building resilience. That's one of the ways in which we know we can do that. But just a plug for our joint strategic needs assessment information on, as we've mentioned, on the Norfolk Insight website. That has a whole section on resources all to do with health inequality. So those are at least 3 ways public health can help.
Thank you. Anybody else want to contribute on? Thank you, James.
Well, I just wanted to say as well, the ICB, if it's about anything, needs to be about trying to tackle disadvantage. So health disadvantages on the basis of race and on the basis of disability and on the basis of poverty. And so we can't be blind to those factors. Actually, we do need to be rather interventionists in both with communities and areas where we see that disadvantage, and that's a conundrum because it means you have to disinvest somewhere else where perhaps you don't need as much service. And I think it's one of the thorny issues that the ICB is just in the foothills of, but if we don't try and tackle it, we won't tackle health inequality.
Sorry.
I'll say something. In terms of children, one of the most important things to close the gap as they develop over time to be able to experience economic well-being is access to education and to good quality education. But to do that, that's what happens for children from the moment they're born, particularly in those first 2 years of their lives, are very critical for them being able then to go on and access the education that will then follow more formally. So thinking about how we work collectively as a whole county to encourage the toddlers to talk, to engage very actively with their parents, but with whoever they come into contact with, so that they start to acquire language. And that makes such a huge difference. And many, as we grow up, adults that experience inequality, when you look back over their lives, have actually not been able to acquire those very early stages in their as foundations to go on and experience economic well-being. So we are trying, as a partnership, to think collectively. We work with public health as well, but also with the Department of Education to focus on talking, language acquisition, a whole series of campaigning. And I'm going to mention in a little while a whole piece of work we're doing called Flourish, and it kind of plays into that in order for our children to flourish. So that's if we reel it right back, if we can put our efforts into helping our toddlers speak and acquire language, it makes a huge difference.
Do you want to continue on the Flourish strategy? Because that's one of the questions that has arisen. How can we ensure that children are included in all our plans, and will all stakeholder partners be invited to demonstrate how they have contributed towards the delivery of the Flourish strategy? Absolutely. So I'm sure there'll be lots of people in the room who don't even know what the Flourish strategy is. So if I just say a little bit about that. So we have a partnership of system leaders, as we've described, which are a combination of people from public sector organisations and voluntary organisations, wanting to unite the entire county around a shared aspiration for children. So what we want is for every child in Norfolk to flourish. But flourish, as a word, has a series of letters, and those letters represent things that matter to children most in their lives. These are the things that children have told us. We did an extensive piece of consultation with children, and what children said, the things that matter to them is their family and their friends. I have got this written down, well, I tried it off the top of my head. Family and friends, learning, opportunities in life, to be understood, to experience resilience, to be respected for their individuality, to experience, to be safe and secure, and to be healthy. And that spells out flourish.
So we have all signed up to the notion that, you know, we should, whoever we are, be able to make any contribution to the lives of children across those letters of flourish. And we want to reach out beyond the public sector and the voluntary organisations, who are extremely important and must make that contribution, but also businesses, local community groups, so that it becomes a whole county endeavour. And you know, going back to that point about toddlers, you know, just being able to go into maybe the local cafe and have something to read, or people talk to them and engage. There's lots of different small ways and big ways. So we have a strategy called Flourish. We have those outcomes attached to those letters. And we wanted to make it real. We don't want it to be a strategy that sits on a shelf and just sits with organisations. It comes out to everybody. And we're inviting people to make pledges, something over the next 12 months. This is going to be a long-standing strategy. It's an ambition for Norfolk for as long as it can be. But in the next 12 months, make a pledge of what could anybody do to make a difference in children's lives against those letters. And that's already beginning to start to happen. We've got about over 100 pledges right now, and a growing number of businesses and local community groups wanting to make pledges. But we will also want to hold people to account, particularly the public agencies who have signed up, including the County Council, of which I am part. That if we've signed up, then what does that look like? What have you done? What have we done? And we will keep reviewing that on an annual basis, and we want to be sharing that out. So it's the beginning, I hope, of a bit of a movement for us across the county, where we can begin to kind of have that in our language, and that we can all think about what are the small things and the big things that we can collectively do to make a difference.
Thank you. I would just add a shout out for beavers, squirrels, cubs, brownies.
Absolutely.
And all those wonderful community
Absolutely.
groups that do so much for the young
Absolutely.
people and give them focus and challenge and so on. So thank you for that. I'm going to turn to the whole sort of digital environment, which I hope is going to... there's two specific questions here. And the first one really is probably for you, Stephen, course, as in terms of funding. What work is planned in terms of IT systems and networks to help ease transfer of information? We've already talked about the shared care record between partners in the integrated care system, and how are you avoiding the problems of digital exclusion that affect some of the most vulnerable people we serve? And there's a supplementary question, which is the importance of human interaction, of human contact. There's no greater comfort than human connection, which is that well-known quote from Dame Claire Marks on being diagnosed with pancreatic cancer. So how do we make the most out of the whole sort of digital environment? We've all had to come to terms with Teams and Zoom and all the rest of it, but how do we retain that essential human connection? And that's really a question for all of you. So Alice, we haven't heard from you for a couple of minutes, so how does the digital world mean, how's that moving for you guys?
So I have to say, my children look at me when I'm using my telephone, my mobile, and say, for goodness sake, Mum, I am probably a digital dinosaur compared to others. However, COVID has made us really, really review how we do things. Now, I do know that in many instances, the introduction of technology and virtual appointments has made a huge difference to our younger community, to teenagers who otherwise might not have engaged in certain consultations, have done so with quite significant positive impact for themselves. So we have to accept that there may be groups that are really using it and really using it well, and there may be groups that really do not like it. And I think that's about us having that ability to be able to offer people something that will suit themselves. Clearly, virtual appointments within a hospital setting are something that we do move towards and do have a lot of. it doesn't mean that every appointment will be sitting on a computer screen. It absolutely doesn't. There is the opportunity to meet somebody face to face, and that human connection can still be made over a screen, and we know it is different, but it can still be there. People are saying one of the feedbacks is they feel that when they talk to the consultant is talking to them. He's not doing his computer, he's not doing anything. That interaction is a much stronger one. So I think there is something around looking at every individual, every case, and no one size fits all. We know that. And that's something we are working through and learning. But I think certainly digital technology and the way we're using it is making a difference to many people.
Thank you. And Stephen, from the point of view of community health, is how do you square that circle, or face those two challenges of digital adoption and still the human connection?
So I think similar to Alice, I think it's got to be. It can't just be one or the other. I think one of the things COVID did was we went very much to digital. That didn't work for everybody, but there is a hybrid in the middle, and we've got to find that. I think just to add something different, I think part of the work we've got to do, I'm talking internally for NCH&C, but it might be shared experiences. Culturally, it was difficult for staff as well, and what might happen is that people return back to the way that they were, because certainly when I trained as a nurse, there was no digital thing like that, so people naturally will gravitate back to it. I think we've got to get a really clear story narrative about where it is better. So there are some services where it is a better interaction. I think Alice mentioned some. Access, speed. I think the management of some long-term conditions, I speak personally, asthmatic, haven't seen my doctor for 3 years, but all my meds, I've had med reviews, I've had all sorts. I'm happy with that, but that's my personal experience. Otherwise, it would have been a bit difficult. The other bit I think we do really have to watch, though, and it links to a previous question, it's not just digital inequality, and often we think about that in terms of, have you got broadband, have you got all those things that help you do digital? The other bit that we're talking about internally is that digital poverty. So if you were in a cost of living crisis and your appointments are set up, but you can't afford to put the data on your mobile to do it, you start making real choices about, am I eating or am I having that appointment? And that will drive that health inequality that we've already seen. So I think it really offers real potential. Some of the things we're looking at around digital monitoring, remote monitoring of patients, how it can help those with dementia is just phenomenal. But we've got to tailor it, and it's not a one-size-fits-all, is my thought.
Thank you. And from an ICB point of view, what's the situation with investing in the whole digital side of things, Stephen?
Yeah, so one of the pieces of work we've undertaken and kind of coming to a conclusion at the moment is around a digital strategy and a roadmap to support that, which really is an assessment of kind of where we are now and where we need to get to, and looking at what's kind of an acceptable level of investment and measuring ourselves to see where we are now. And that will be a lot of the things that people on the panel have already said around, there's not one size fits all for this. So in our investment, some of that digital infrastructure we might need to put in may be for the benefit of our staff as well as some of our patients as well. Because some of that sort of digital poverty, if you like, might exist within our staff groups, thinking particularly around primary care, for example, and making that experience easier for them to do their jobs, which will allow them to give a better service, high quality service to our patients. We've got some national things that we're looking at as well, and looking for funding from those nationally, which are around strengthening our electronic patient record systems. We've already talked about the shared care record today as well, which is a continued investment that we'll continue with. But I think the real critical piece of work for me is to really understand where our gaps are, so we can start to address where we need to really strengthen our investment, and then plan how we're going to do that, and do that in a way that really supports our communities to do it.
Thank you. For the sake of clarity, what's the difference between, or what's the connection between a shared care record and an electronic patient record?
So electronic patient record, for me, I'd be interested, others might have a different view on this, but electronic
patient... I wasn't pointing at you necessarily.
Yeah, electronic patient record for me is something we would use in a provider setting,
Yes.
which allows our staff ease of access to record the interaction and the history of what's going on in the treatment of a particular patient. A shared care record allows us to take all of that data across our providers to get one kind of version of what's going on with that individual. I think we mentioned earlier, you know, an ambulance turning up to somebody that's in a particular situation, having all of that information available, which will draw on that electric patient record that might have been used in the hospital with what's gone on in the GP practice, is going to be the really critical thing around the shared care record.
Perfect answer.
Good, thank you. just for clarity, actually it was because I wanted a bit of clarity because I was slightly confused, so thank you for that. I'm going to come on to, obviously, one of the questions that we're all very aware of, and it's probably going to be a question to absolutely everybody, because what measures are being put in place to improve access to mental health services? When will mental health be given a higher priority so people can be seen within a more reasonable timescale? Will more counsellors and therapists be recruited at any point? And I appreciate we may not have a subject expert here, but it is probably a question for absolutely everybody, and maybe even from a public health perspective. Suzanne, to start off with.
I think it's difficult for me to comment about the provision of treatment, so,
Sure.
so I'll let colleagues in the room to do that. But in terms of keeping ourselves mentally well and preventing a deterioration into needing services, that's very much a public health area of interest. Because just as we would look at physical health, so we look at ways we can improve our well-being, keep ourselves well, very much like the presentation we heard earlier in terms of building our resilience and knowing where to go or what to do early on when we need help. And so that's very much a public health message that obviously, as in physical health, prevention is better than cure. And so we would very much welcome as much investment, as much opportunities for us to improve our well-being across the patch, across the whole population.
Okay, thank you. And just to remind you that questions will be, we will get written answers to the questions to make sure that we've covered them all appropriately. We're coming towards the end of our session, but I think that there's a question that I do want to ask, which is around, and this is probably one for you, Stephen Course, I dare say, the big funding issue about big infrastructure projects like hospital programs and so on. Alice may wish to jump in at some point and talk about acro props in Queen Elizabeth Hospital and so on. But this is almost the elephant in the room, isn't it? Some of our hospitals are aging. There's been talk over the last few years about major investment in new hospitals. Existing hospitals are bursting at the seams and so on. So where do you see the world going for these big infrastructure projects?
I mean, internally within the system, we've got really well developed plans around what we want to do with both of the sites that you've mentioned, and how we develop those into a position where they're much more sustainable than they are now and don't require the kind of propping and things that we're having to do to keep those facilities operational at the moment. There's national programmes that we know around those, and we are hopeful that both of those schemes will be on future waves of those funding opportunities. But we need to continue to work hard with national colleagues to ensure that we do that. We've done some work initially around how we would kind of do that transition through the construction phase, if you like, so that we can ensure we're still able to provide services as we move through. We're also using other colleagues around the NHS who are in a similar position with similar constructed hospitals, and what we can learn and share from those so that we can kind of build a solution that's resilient and robust as we move forward. But I think the job for us is to continue really pushing hard with our more senior national colleagues around ensuring that as soon as we get an opportunity to put these things on the table that we can do so.
Alice, do you want to add anything to that?
Thank you for the opportunity. I guess we continue to deliver the programme that we have got at the Queen Elizabeth. We've got a significant piece of work that we're doing around ensuring that our props are appropriately managed. We continue to monitor the walls, the ceiling, we make sure the ceiling doesn't become the floor. We've got teams that are on it every minute of the day. We're looking at how the building is holding up. So there is a significant RAC project, for want of a better word, And that project will continue until the point at which we have an organisation and a building that is as safe as we can get it. Now, clearly, a new hospital is something that we continue to work nationally towards. We do not have a defined answer at this moment in time. But I think what it is not stopping us doing is continuing to develop services. So last week, some of you may have seen, we opened a brand new state-of-the-art endoscopy unit. It's stunning. And as you come into the organisation, it is a new build that we have had put there because we knew we needed more services and we needed better services for our patients. So we will continue to do those projects. We will continue to work with the national team, with the ICB, and with our other organisations should we need extra support. But our props are lovingly monitored and managed.
Thank you. And best wishes for good news later on in the year, hopefully.
Thank you very much.
There's, again, coming back to the sort of conundrum of digital versus personal, there's a question here which I will read in its entirety. There is much evidence that personal continuity of care results in better clinical outcomes. How can you encourage personal continuity between patients and clinicians? Please do not answer this with reference to informational continuity via record systems. This question is clearly about developing professional relationships to enhance care. Stephen, is that a good one? And Alice, it might be one to come your way as well.
Yeah, and I think there's a couple of examples I would give. So I'll go back to my visit out with the ambulance trust. So what was clear is, and I think it's happened over a number of years, is that we have become quite task orientated in a number of settings, and I can certainly talk for our district nursing service. So one of the bits we're looking to do over the next 18 months, or hopefully quicker, is unpick that so that when we shape our teams around those primary care networks, so your primary care team know who their community team are and work really closely, so they feel like one team, they don't feel like two separate bits. And the district nurse who comes in, hopefully, is the one that will keep seeing you rather than, I mean, there's always a bit of, they're not working 7 days a week, 24 hours, but there's much more continuity we can do around that. So I recognise from an NCH&C point of view, the way that it's currently structured and the way that we've developed it over time needs to change. That's not a digital solution. And my other one would be, and I'll use Alice as Alice and I can use as an example, is we've got community beds in Swaffham, and there's James, who's the frailty lead in the QE, is now looking over both those elements. So you'd see James in the QE, you could have come in, and then if you transfer to our community hospital in Swaffham, James is your consultant over there. So you've got a continuity of a person that you've grown to know and trust that is working, and we're looking to do something similar with an NUH around some beds there. So I think it's looking for those opportunities where we create that one team and there is somebody that you recognise, that you've told your story once to, who understands you, and it follows you all the way through. So that's a couple of examples of what we're going to try and do. There's a lot more we need to do around that.
And you've just nicely mentioned one of the important phrases about the commitment of the integrated care system, this idea of the patient only having to tell their story once, which I think we would all love to go back to from the days when we used to have the family doctor who would come to our bedside when we were sick at home and so on. And obviously we realise that the world's moved on quite a lot, but that sounds really encouraging, and thank you for the time frame as well. Mindful of the time and of the fact that there's still another page of questions, which I'm not going to get through, can I ask you all to show your appreciation for some very frank answers and for the time these people have given us. Thank you. Thank you very much indeed. And as I said, all the questions will be answered in full on our website, hopefully before too long. And before we close, I'd like to invite Louise Ansari, who is the Chief Executive of Healthwatch England. I nearly did it again. I nearly gave you control over the whole of the UK. But as you've said, that'll take another week or two. But Louise, if you'd like to just tell us a little bit about where Healthwatch and Healthwatch England fit into the health and social care sector, and any updates on your work nationally, and generally any comments about what you've heard today and Healthwatch and so on. Thank you very much.
So
Thank you, Patrick. Morning, everybody. Gosh, that was a fantastic discussion. I'd learnt a lot about what you're doing here in Norfolk and Waveney. And a real privilege to be here. Thank you very much for having me. I was in Suffolk yesterday meeting with Healthwatch Suffolk, but obviously you're better than them. No, there are some amazing Healthwatch across England. Most of the Healthwatch across England are amazing. And at Healthwatch England, we hold Healthwatch Norfolk in very high esteem for the work that you have done. And some of the work has been referenced today. Alex did this phenomenal roundup of the work last year. I loved the graphic. I thought that was great. And we're very impressed, and I'm very impressed today, with the very close working relationship that Healthwatch has clearly got with the different parts of the system, public health, the ICB, the trusts and so on, as evidenced by this very distinguished panel here. So that's really great. And relationships are the key, aren't they, to ensuring that patient and public voice gets into the system, and then you guys change what you're doing because of the experience of people. So I can see that flow, and the questions were very, very good, and the answers were great. And one of the things, and there's a tiny bit of discussion about inequalities there, one of the things that Healthwatch Norfolk has done to really great effect is work on accessible information. And you've spoken about that a little bit. That, for me, feels really core to the Healthwatch movement. It's people who find it actually difficult to navigate systems and even, understand things like letters from GPs or from the hospital, or know who to ring, or what their advice is about a cancer pathway or their medicines. And one of the things that Healthwatch Norfolk has done brilliantly, I know, has done this work on accessibility, including digital exclusion, that's made a really huge difference. And that will reduce inequalities, because that's about equality of access. If you can understand the letters and you can understand your treatment and you know where to go, that's one of the really basic things about health and care. And for me, it's very important in at Healthwatch England and everything we do. Some of the things we're going to be focusing on, we're going to carry on banging on about access to GP services and about dentistry. And I know that you've been doing a huge amount there. Now, because of the work you've done and because of the work Healthwatch England has done, you will notice that whatever you think of the new government, that both the Prime Minister and the Secretary of State for Health, with her ABCDs, has got doctors and dentists as a part of that. Now, I genuinely don't think that they would be mentioning dentists had it not been for the work that you've been doing over the years and Healthwatch has been doing over the years. So that is a genuine achievement. We are feeding into what they might actually do, rather than just the kind of slightly superficial statements. But that's the achievement of Healthwatch England Network has been amazing. We are also going to focus on social care, because as colleagues have said, and as you all know, that the difficulties that lots of the health system are facing is because social care is broken. It means if you can't get the social care you need, then you're going to end up being transported to the hospital. If there isn't any social care for a care package to leave hospital, then this whole flow thing means that people are unnecessarily stuck in hospital and not getting the care they need. One of the things, so maternal mental health is another area that we're going to be looking at. So social care, access to primary care, maternal mental health, still a focus on long COVID, and a range of other areas that are going to be familiar to you. But one of the things I wanted to say today, and I'm only going to speak for a couple of minutes, is that nobody's really mentioned, there was a bit of an allusion to it, but nobody's really mentioned that this winter is going to be one, and already is one, of unprecedented pressures for the NHS and the social care system. So what does that mean for us? What does it mean for Healthwatch Network, Healthwatch England, the Healthwatch Network, and its relationship with health and care bodies? Well, it means that there is actual potential for more harm for patients and the public. If the ambulance doesn't turn up and somebody's fallen and they're on the floor for 7 hours, maybe they've got a hip fracture, then their risk of severe illness and death increases. So there are some really tricky issues coming up over winter. If there aren't beds in hospital, if A&E waiting times are very long, you know, a whole range of issues. If people are still on waiting lists, they're not getting mental health care, then that's going to be really problematic. Workforce underlies that. So what can we do actually to help? Because sometimes over this winter, to be frank, because of all the pressures, even if we say this isn't working, the leaders in health and care might say, I'm really sorry, there's nothing we can do about it. So it might not be a performance issue. So what do we do to kind of support that? Well, one of the things I think we need to do is do more on supporting initiatives in the community to support people on the cost of living. And that has been referred to a little bit. You know, there was that thing on the Today programme this morning about people not being able to afford broadband at the moment and the implications of that on whether or not they're going to be getting digital appointments. So there are a range of things. I've started to hear that Local Healthwatch are working with colleagues in the voluntary and community sector to direct people to food banks and to benefits advice. So it may be that we can help, and it may be that the ICB can say, yes, we're going to put some more into that to actually support people to be well, and indeed public health, support people to be well at home. And then I'm sure that you'll have a winter plan. Have you got a winter plan? Yes.
We have.
And one of the things I think Healthwatch need to do is feed back in real time how the winter plan is working. So sharing what the winter plan is and feeding back hopefully will be helpful to all of you. So that's another area. And then on supporting hospital discharge. So Healthwatch, for example, I don't know if you already do this, Alex, but Healthwatch in Brighton and Hove, for example, has had a programme of ringing people who leave hospital. Sometimes they don't need a full care package. Sometimes they just need somebody to check on them or bring them some food or, you know, have somebody just visit to say hello. And that has shown to reduce emergency readmissions by something like 70%. So supporting discharge could be an option, and all the team will have an understanding of what might be best in that context. And then the other thing I would say is that Healthwatch is very good at being the critical friend and pointing out where services are not working, and that's absolutely right, that's our job. But at a time when morale in the NHS is probably at an all-time low, I think we should be really careful to also relay the positive experiences of health and care that people receive and get those back into the people who are working on the front line, so that at times they're hearing some good stories and they're hearing, actually, that worked really well and they had some really good care at the GP or in the hospital. So I think that balance, which I know some Healthwatch are really, really great at, would be good. So as well as the long-term strategic, you know, what are we going to do in Norfolk and Waveney over the long term, I think finding a way to work together potentially a bit differently over winter might support patients, might support the NHS in the long term. So, just very briefly, one of the things that Alex mentioned was that brand awareness of Healthwatch Norfolk has gone up. And brand awareness of Healthwatch as a concept, as a movement, has gone up. It was 34% of the general public had ever heard of Healthwatch a couple of years ago. This year it's 40%, so it's gone up. That's an average. Healthwatch in the east of England is 50%. So hats off to your communications people. And all you need to do now is find the other 50% and let them know about Healthwatch. I'm going to end on a slightly serious note because I'm concerned about the financial sustainability of the Healthwatch network as a whole. Alex pointed out that grant and aid and funds have reduced over time. That's the case for everywhere in the country, from around about nearly 50 million being given to the Healthwatch network when it started out 10 years ago. It's now around 25 million. And that's a real worry because we are needed more than ever to feed back patient and public experience into the system. So ongoing support by the County Council and the Integrated Care Board, I think, will be really welcome and for Healthwatch Norfolk and Waveney. Final word is to pay tribute to the excellent work of Healthwatch Norfolk as I say, held in incredibly high esteem by Healthwatch England. So thank you for everything you do to support patients, public and communities across this area.
Louise, thank you very much indeed. There was some really good hard-hitting information in there, some good suggestions, and thank you for the encouragement and support as well. That brings our first Healthwatch Norfolk Live to a close. I'd just like to say a couple of thank yous once again to our panel of people who I know are under real pressure. Thank you so much for giving up your time today. Thank you so much for your honesty and your openness with the answers to the questions. And that's part of the reason I'm sure that we had such a good turnout from you, the audience, today. So thank you very much for coming along today. Just in terms of thanking the people who've put this today together, Alex and your team, fantastic. Thank you very much indeed. To the guys from the forum, thank you very much for a fantastic venue and an AV system that absolutely worked, even though you may have filtered out some of the slides accidentally or on purpose, I don't know, but at least you made sure that those speakers kept to time. So good one. Well done. Thank you very much indeed. And once again, thank you to all of you for turning up and for helping to make Healthwatch Norfolk a successful body that really listens to the voice of the patient and makes sure that the patient experience gets shared with our health and social care providers. Please don't feel you have to rush off. If you want to have chats with people from Healthwatch, our trustees are here today, and I'm sure that some of these people will feel they need to get away, but if you want to have a word, do try your best, because they are great people who do listen and do talk. Thank you very much indeed, and hopefully see you in a year's time. Thank you.